Hello friends, today I am going to explain you treatment outline for early laryngeal cancer. We will talk about each three subsides of larynx, glottis, subglottis and supraglottis. We will not talk about locally advanced disease today. We will do that in separate lecture. When a patient walks into your clinic with an early laryngeal cancer, what should be our mindset? Our approach is always with a curative intent. We want to completely cure the disease. But curing the patient is just one part of our job. We have to follow a very simple rule in our daily practice. We must achieve a cure with the best functional result. And we must do this with the least risk of serious complications. Why do we worry so much about the functional results? Because these early cancers respond very well to treatment. If you see the survival rates from the observational studies, they are excellent. For patients with stage 1 disease, the 5-year survival is more than 90%. For stage 2 disease, it is around 80%. This means our patients are going to live for a very long time. So the treatment you select must offer high local control. It must also give the patient a great chance at long-term overall survival. Now let us move to our next major goal. This is organ preservation. But preserving the physical organ is only half the battle. We must also preserve its function. Function, not just anatomical preservation. When we talk about functional preservation, we mean three important things. First is swallowing ability. The patient must be able to swallow safely. They must protect their airway to prevent severe aspiration. Second is airway patency. The larynx must stay open to give a safe airway. We want to avoid a permanent tracheostomy for these patients. And the third is voice quality. The larynx is our main organ for communication. We must preserve the vocal cords so the patient can speak clearly. Let us look at this, a very important clinical rule when we are dealing with early laryngeal cancer. It is the single modality paradigm. You must remember this rule for early laryngeal cancer. We have two great options to save the larynx. We can use larynx preserving surgery like Transoral Laser Microsurgery surgery or TLM. Or we can use definitive radiotherapy. But the goal is to use only one of these methods. You must avoid multi-modality therapy. Do not use surgery followed by radiotherapy for early disease. Choose only one which you think will be the best for this patient. Why should we avoid multi-modality treatment? Because combining surgery and radiation increases side effects. It causes severe complications and poor function. And it does not improve survival for early stage disease. So, always aim to cure the patient with just one treatment. Now that we understand our main goals, let us move to discuss the treatment outline and options available for early laryngeal cancers. This is the part where we decide exactly how to cure our patients. As we discussed earlier, we are talking about stage 1 and stage 2 tumors today. Our primary aim is always to save the larynx and keep its normal functions intact. To achieve this, we have two highly effective treatment options in our daily practice. We can use radiation therapy or we can use laryngeal preserving surgery. Let us first look at the fundamental approach for these patients. For early stage disease, our standard of care is a larynx preserving approach. We want to save the organ without compromising the cure. To do this, we broadly have two main options. The first option is radiotherapy, the second option is surgery. Now, if we look at surgery, it can be done in two ways. One is the traditional open surgery, and the second is the modern endoscopic surgery, which is mainly TLM. You will notice that we emphasize the laser over the traditional scalpel here. This is because modern laser surgery has largely replaced open surgery for early tumors. Let us explore these modalities one by one. Let us first talk about radiotherapy. Radiotherapy is a non-invasive modality. This is a very attractive option for many of our patients. Why is that? Because it completely avoids all surgical risk. It also completely avoids any anesthetic risk. You have 0% surgical and anesthetic risk here. This makes it a highly preferred modality in our daily practice. More importantly, it yields excellent organ preservation. The patient gets to keep their natural voice box. They get cured without ever entering an operation theater. Now, let us talk about surgery. Surgery is an invasive modality. When we take the patient to operating room, what is our main goal? Our first priority is the complete removal of the tumor. We must ensure that we get completely clear margins. But we must also remember our goal of functional preservation. We cannot just cut out everything. We have to very carefully spare the normal healthy tissues. Why is this so important? Because this is the only way to maintain proper laryngeal function. We want the patient to speak clearly and swallow safely after the surgery. Now let us see how surgical management has evolved over the years. If we look back in time, we used to rely heavily on open partial laryngectomies for early laryngeal cancer. These were major open surgeries. We had to cut through the neck from the outside to reach the tumor inside. But medical science is always advancing. Today, there has been a massive shift in our surgical approach. Today we have moved away from those open surgeries. We have now shifted to endoscopic surgery. Specifically, we are talking about Transoral Laser Microsurgery, TLM. This is a major advancement in our field. Instead of making a cut on the neck, we now operate through the natural opening of the mouth. We use a highly precise laser to remove the cancer completely. This evolution has made surgical treatment much safer and easier for our patients. Let us understand exactly why this shift happened in the next slide. Let us look at the traditional open surgeries first. In the past, we used procedures like vertical hemilaryngectomy and open cordectomy. But these surgeries are highly morbid procedures. They take a heavy toll on the patient's daily life. After these surgeries, the patient often ends up with poor voice quality. They also suffer from delayed swallowing. Because of this, there is a very high risk of aspiration. The patient will need prolonged Ryle's tube feeding just to get proper nutrition. Imagine the discomfort of being feeding tube dependent for a very long time. These patients also face much longer hospital stays, and very importantly, they may need a temporary or even a permanent tracheostomy to breathe safely. Because of all these surgery related morbidities, our daily practice has changed. We rarely use open surgery as the first treatment for early tumors today. Instead, these surgeries are now primarily reserved for salvage treatment. We use it mostly for treating recurrences after radiation therapy fails. Now, let us talk about the modern surgical approach for early laryngeal cancer. Today, our surgical treatment of choice is endoscopic surgery. Specifically, we use a technique called Transoral Laser Microsurgery, TLM. We sometimes call it laser cordectomy. This is a highly precise, minimally invasive procedure. Most of the time, it is done as a daycare procedure. How do we do it? We operate entirely through the mouth using a surgical microscope. We use a highly focused CO2 laser or a KTP laser to gently excise the tumor with an aim to get tumor-free margins. This extreme precision is exactly why we prefer it over open surgery. It completely avoids the high morbidity of open surgeries. There is no cut on the outside of the neck. There is no need for a tracheostomy. The patient gets to home early with a much faster recovery. And very importantly, they have better swallowing outcomes. Now let us move to a very crucial concept of our discussion. We divide the larynx into three distinct anatomical regions. We have the supraglottis at the top. We have the glottis in the middle, which contains the true vocal cords. And we have the subglottis at the bottom. Why is this exact anatomy so important for us to know? Because our entire treatment strategy fundamentally shifts based on this exact location. A tumor sitting on the vocal cords behave very differently from a tumor sitting above them. They have completely different lymphatic drainage networks. Because of this, they carry different risk of spreading to the neck nodes. Therefore, our approach to treating both the primary tumor and the neck will change. In the next few slides, we will discuss the specific management for each of these three sites. Let us first discuss the management of early glottic cancer. As you know, these tumors are located on the true vocal cords. For the primary tumor, we have two excellent choices. We can use either radiotherapy or Transoral Laser Microsurgery, TLM. Both of these modalities offer equal and excellent survival rates. Both of these modalities give equal speech outcomes in general. Now, what should we do about the neck? This is a very common question in the clinic. If the neck nodes are clinically negative, you must simply observe. We should not treat the neck electively in these patients. Why is that? It is because the true vocal cords have a very poor lymphatic network. The risk of the cancer spreading to the neck is negligible, less than 5%. Therefore, we spare the patient from unnecessary neck dissection or unnecessary neck irradiation. Now let us move to supraglottis. This is a completely different territory. Early supraglottic cancers are generally more aggressive than glottic cancers. But for the primary tumor, our main option remains the same. We can treat the primary tumor with either radiotherapy or surgery. Both of them have equal outcomes in general. Now, what about the neck? This is where the management completely changes from what we just learned about glottis. You must always treat both sides of neck electively. Why is this so important? Because the supraglottis is a midline structure. It has a very rich network of bilateral lymphatics. This means there is a very high risk of hidden or occult spread to the neck nodes. Even if the neck feels completely normal in the clinic, you must treat it. You have to cover levels 2A, 3 and 4 on both sides. If you are treating the primary tumor with radiotherapy, you simply need to do elective bilateral neck irradiation. If you are treating the primary tumor with surgery, you must perform elective or prophylactic neck dissection. Never leave the neck untreated in these patients. Now let us move down to the subglottis. Subglottis cancer is very rare, but we must be very careful when we see these patients. These tumors are considered highly dangerous. This is because they can cause rapid cartilage invasion. They can cause severe symptoms, especially stridor. They can extend down into the trachea. So what is our primary treatment of choice here? We strongly prefer definitive radiotherapy over surgery. There is a debate about surgery versus radiotherapy for early glottic and supraglottic, but there is absolutely no debate about subglottis. The treatment of choice for this site is radiotherapy. Radiotherapy gives maximum chances of excellent organ preservation than surgery. We want to avoid a major open surgery to give the patient the best chance of saving their voice box. When we plan the radiation, we must define our treatment scope very carefully. We have to radiate the primary tumor, but we must also include the draining lymph nodes in our radiation field. This specifically means covering the pretracheal and paratracheal nodes in addition to bilateral level 2, 3 and 4 levels. Let us quickly summarize everything we have learned so far. This slide gives you a summary of our site-wise treatment. Look at the glottic cancer first. The primary treatment is either radiotherapy or TLM. For the neck, we simply observe. We do this because the true vocal cords have poor lymphatic drainage. The risk of spread is less than 5%. Now look at the middle row for supraglottic cancer. The primary treatment remains RT or TLM. But the neck management is completely different. You must electively treat both sides of the neck. This means covering level 2A, 3 and 4. Why do we do this? Because the supraglottis has a very rich lymphatic network. Finally, look at the bottom row for subglottic cancer. For the primary tumor, we strongly prefer definitive radiotherapy. For the neck, we must treat the pretracheal and paratracheal nodes also. We must be careful here because there is a very high risk of cartilage invasion. Please keep this simple summary table in your mind. It will always guide your clinical decisions in the outpatient department. With this, I end my lecture. In next video, we will dive deep into a great debate. TLM versus radiotherapy for early glottic cancer. It is going to be a very interesting lecture for all those who are beginning their career in oncology. So stay tuned. Thanks for watching. Signing off, Parveen Ahlawat.